hour. So thank you. This is super exciting to see so many people join in this session. So thanks to all. As you know, this is the Africa Echo session, and our topic for today is bridging the diagnostic gap, molecular pathology applications for cancer in Africa. So we have a slightly different format today because we have 3 speakers, each speaker will speak for about 10 minutes, and then we'll have a discussion session at the end. So we'll start out with a case which will be presented by Dr. Asteria Kimambo, sort of talking about her experience in her setting in Tanzania with challenges in breast and lymphoma pathology. And then we'll have Dr. Ed Bierchuk, who is a hematology oncology fellow at the Fred Hutch in Washington, speak about some of the work he's doing in developing molecular diagnostics in lymphoma. And then we'll have end with Dr. Brock, Jane Brock, who is an associate professor at Harvard Medical School and a breast pathology expert. Without further ado, I'll just have the speakers go. So we'll try to be pretty strict with the timing so we can have time for discussion. So I'll give 1-minute warnings to the speakers as they're getting close to the end of the 10 minutes. Thank you all for joining. So we'll start with Dr. Asteria. And Charles can help manage the screen share for her.
Yeah. Thank you, Dio, for the introduction. Yes, there we are. Yes. So thank you, Dio, for giving me this opportunity to share my experience of breast and lymphomas gaps that I've experienced for the past about 5 years in sub-Saharan Africa, with more focusing on my country, Tanzania, to try to see how we can bridge the gap of using molecular pathology in diagnosis of this tumor. Next slide, please. This is my outline. Next, yeah, this is where I'm working now. Yeah, to your left, this is the university side. On your right side, this is the lab, the pathology lab where I'm working. Next slide. Next. Next. Yes. So in 2012, Global Can have reported that in our country, the breast cancer is the second leading cause of cancer and cancer-related mortality among women. And we have found that the mortality to incident ratio of 0.5. And this has shown that this is one of the most common cancers that we are battling.
I might have lost Dr. Kimambo's audio. We'll wait for a couple of minutes to see if she's going to be able to rejoin. Can you hear us, Dr. Kimambo?
The internet is not that stable, so I'll stop the video.
Okay.
Yeah, I can stop the video so that I can improve my bandwidth. Can you hear me, Dad?
We can hear you now. Yeah.
Okay, yes.
I'll ask you for a minute. Yeah.
Okay, thank you. So as I've said, yes, so the next slide. So this is the Global Can report on 2020, and we can still see breast cancer is the second leading cause among the list, second to cervical cancer. And with regard to lymphomas, for non-Hodgkin lymphomas, it ranks the 6th most common cancer. So it's among the top 10 cancer that we're battling here in our country. So these are the most very important cancer that we really need to focus on and try to see if we can. Next. Yes. So most of our patients usually comes at stage 3 and 4. So most are in advanced stage, and several studies have been done in different parts of the country and shown for breast cancer and even the lymphomas. Most of these patients, when they come to us, they're in stage 3 and stage 4. Next slide. Yeah, and this has been contributed mainly by our referral system, because when the patient comes, usually they're coming from the community, they go to different routes, they go to dispensaries, they go to health centers, and then they'll move to district hospitals, because we are, most of the areas have been divided in districts. They go to regional hospitals, and then they'll be referred to zonal hospital and to tertiary big hospitals. This is where they will get pathology services. So the delay is most of the times within this route the patient goes because of our referral system, and we cannot change that because this is how the patient goes in a routine ways. So majority of the patient will come to us where there is pathology services, but they are all in stage 3 and 4 because of the system. So this is among the area that we really need to work on in most of the sub-Saharan countries, because we have that is the same way where the patient has been referred. Next. Next, please. Yes, this is shown the delay. So in terms of the diagnosis, comprehensive diagnosis approach is the key issues for effective treatment of breast cancer as well as lymphomas. And this will determine the patient prognosis and their survival. So in my area, usually when the patients come, we do cytology. So for breasts and even for lymphomas, if they come with neck masses or mass in the axilla or mass in the inguinal areas, we do perform fine needle aspiration biopsy. Oftentimes, not always, we do imprint cytology and cell blocking, but we all do fine needle aspiration biopsy, and then we refer this patient back to the surgeons for open tissue biopsy, and this can take different routes. They can do core needle biopsy, or they can go and do incisional biopsy, depend on the age of the patients, depend on the status and the stage of the patients. But also sometimes they can do mastectomy with the fine needle aspiration, but commonly they do core needle biopsies and open tissue biopsies, and they will send to us. And we'll do the histological diagnosis, the H&E diagnosis, we'll stage, and then we will go back to them and ask for payment for performing other additional tests. For example, the breast cancer biomarkers, these are not done upfront, is up until the patient they paid for that. And even for lymphomas, we just do H&E, but we wait until the patient paid for markers so that we can characterize these lymphomas. So we don't do it upfront. Next slide. Yeah, so there are several challenges that we are currently facing with respect to breast and lymphoma diagnosis in our country. If we focus on breasts, not all the hospitals that I'm talking, the big hospital, the referral national hospitals where we have most of these pathology services, we don't all perform these breast cancer biomarkers, so they're not all available. But if we do, we have a little challenges with regard to the method that we are using now, because the method that currently we are using is only immunohistochemistry when we perform these breast cancer biomarkers. And we have a challenges in terms of turnaround time. It is variable and depend on several factors. This could be due to reagent, but also could be contributed by the patients themselves, because they have to pay upfront before we perform this test. So it may take a week and depend if the patient pay. And this is not covered by insurance, so it may range weeks to months, but also a shortage of highly trained technicians to perform this test because they are tedious and they need someone with a lot of skills. But we have sometimes on and off interrupted supply chain of the reagents. Cost is also there. Equipments, the immunohistochemist now that we are doing is the automated one, and you need a lot of reagents. So sometimes we have cut off the supply chains and we run down of the this immunohistochemist for breast. But we have high variable handling techniques, handling of specimen from clinicians. Sometimes specimen they come, they're not well fixed for breast, and then it may affect the time and the turnaround time. And currently we are not performing the IHC on cell blocks. This is a technique that people have done it in research, but it's a routine practice. Next slide. Yeah, some of other challenges for HER2, we don't do FISH or CISH, both. We don't perform both. And so we have a lot of challenges in terms of equivocal, the HER2. So we have variability in the interpretation of HER2 and deciding on whether the patient should receive Trastuzumab or not. So it depends upon the pathologist to decide and say this is HER2 positive while it is equivocal, because we don't want to not give these patients an opportunity to receive Trastuzumab. So for equivocal HER2, there's a lot of problem about that and the way we report and sending this patient for oncological care. So we really need FISH and CISH so that we can really give out the result which these patients need for their treatment. Next slide. Yes, for lymphomas, also they're the same, not different from the breast. The issue of crushing artifacts, sometimes of the lymph node, they come, they're crushed, so we cannot even make an histological diagnosis. Thick sections, some of the technicians, they don't know that a lymph node need a very thin section so that the pathologist can have a better pathological diagnosis. And for depends because the patient have to pay up front, as I've said, for all the immunomarkers, whether they're for breast or lymphomas or other tumors. We have flow cytometry, but it's not currently in pathology. It is in hematology, and usually they're using this for characterization of leukemias rather than the lymphomas from the tissue. So we are not using the flow cytometry for routine care. We don't have in situ for breast and as well as for lymphomas. And we have a bunch of markers for lymphomas, but also we miss some of the important ones. For example, CD10 is on and off, not always there. For example, CMYC for Burkitt lymphoma is not available currently. We don't have BCL6. We don't have EBA, we don't have latent membrane protein 1, which are all important for Burkitt lymphomas. We don't have ALK protein for anaplastic lymphoma. So these are some of the list of the markers which are missing, and we have some problems in diagnosis of lymphomas. The costs, as I've said, cost is one of the biggest issues.
A 1 minute marker.
Immunos, they're not by insurance, so they have to pay upfront. And this is the list of the costs that I've put. Next slide. Yes, some of the ongoing research activities that have been done now. There's a study done here, try to see if we can try to do the breast cancer biomarkers using GeneXpert. And now currently we are in implementation phase. So we are hoping that if this picks up and we'll be able to implement this, we may bridge the gap for diagnosis by trying to move from IHC to molecular studies. Next slide. So I think most patients come in advanced stage, and accurate and time testing for biomarkers will render patient eligible for cost-effective treatment. And I think molecular platform now is it may be in future being the diagnosis of choice for breast cancer biomarker assessment and lymphoma. And I think the capacity is there. And if we make use of it, it can transform the pathology services in our setting. Next slide. This is the reference. Thank you.
Thank you very much, Dr. Kimamba. So we'll hold questions till the end. So Dr. Bircher can give his presentation. And feel free to type questions in the chat box as well as things are going on.
There we go. Great. And do we have the correct slides up?
Yes, we do.
Okay, perfect. So I'd like to just thank everybody for coming today. This is a fantastic group, and I'm really honored to be speaking with around the diagnosis of lymphoma. So I think that we had an excellent intro, and I'm going to actually talk primarily about work that we developed with our colleagues in Guatemala. So off of the African continent, but certainly a lot of similarities apply with our challenges for diagnosis. So lymphoma, as was mentioned, is really challenging. There are over 80 pathologic subtypes, and we know that treatment for lymphoma can vary from simple observation to intensive chemotherapy regimens, and every day these treatments get more specific for patients. In our high resource setting, we are going to start with our clinical suspicion, and then these cases will go to a specialized pathologist. You'll get all this ancillary testing, as was mentioned previously. And then sometimes we do gene expression profiling. But what we find in a lot of lower resource areas, like in Guatemala, where we have 3 hematopathologists to look at all of the lymphoma cases for the entire country, we have big limitations on equipment and space. And then there's cost. So it's approximately $450 out of pocket for patients in Guatemala to get an IHC-based diagnosis. And that's around 10% of the median income. So clearly problem there. So we hypothesized that perhaps we could skip this step in between and go straight to gene expression to get to a diagnosis. So to do this, we actually started with these books, and these are the records of all of the biopsies that were taken in Guatemala for a suspicion of lymphoma. We corroborated this with the medical record and then accessed those tissues, which was led by our pathology colleague, Mauricio Salazar in Guatemala. And then once we had this, we initially took all of the final diagnoses and we bracketed them into what we thought were the most important buckets as far as what we would do for treatment for these lymphomas. You'll note that some things that aren't on here, for example, Burkitt lymphoma falls into our aggressive B-cell lymphoma because it's relatively rare in Guatemala, whereas something like NKT cell lymphoma we see really frequently, which is not something that we'd see in other parts of the world. So some of this will be adapting for other locations. How often did an Incan diagnosis match once we were able to say, all right, we're going to do all the gold standard on this and make sure that we get a complete finalized diagnosis? So among 643 unique patients, we only had concordance of 38%. Now, I want to stress here, the reason that we don't have concordance is because oftentimes we're left with a insufficient diagnosis rather than a wrong diagnosis. That is to say that it may be we have a large cell lymphoma, but we didn't have the IHC to be able to say this is a diffuse large B-cell lymphoma. So I don't think that this is so much a reflection of how the tissue is being assessed, but the tools to assess it. So clearly, we've got to do a better job because we're getting patients their wrong therapies with these incomplete diagnoses. So we asked whether we could develop an inexpensive method for obtaining gene expression profiles. And what was important for us is, as we've already talked about this morning, when it comes to supply chain, we needed something that's going to be able to move from where the patients are at and getting their biopsy to a location that can do the testing. And so we really focused on using FFPE-based tissue because it gets around a lot of our potential supply chain, the tissue itself and gene expression. We partnered with a company called Dexterity, who had developed a multiplex PCR that allowed us to take small micron FFPE scrolls and do a single tube in-tube RNA isolation. The DNA is actually also there. And then for each target that we're looking at, for each gene, there are a split set of probes. And so these probes on their target end, they have on each side our universal primer as well as a stuffer sequence. And the stuffer sequence is important because as this binds, only when it binds will to the target, so when the target is present, will it ligate. And once it ligates, it can be amplified. But because of those stuffer sequences, each gene is going to be a little bit longer, and we know what that length is. And so then we can run this on any basic capillary electrophoresis machine and produce a gene expression profile. So now we have an individual gene expression profile, and we can combine that with our known lymphoma subtype. And from here, we developed a few different algorithms, but ultimately settled on a random forest and then into an XGB superlearner. And this gives us a final diagnostic probability from that gene expression. And so what does that look like coming out on the end? So I'm going to spend just a second on this figure so this makes sense to everybody. So each of these dots are colored according to what their WHO diagnosis was. Okay, and then these things that you see across the top, this is the bucket that it fell in based on the gene expression profiling. So you see most of these are red. Those were diffuse large B-cell lymphomas. You see a green one here. So this is a follicular lymphoma that snuck its way into the DLBCL bucket. The other thing that I'll point out here is that when we do this algorithm, we get this probability. This probability doesn't mean how sure are we that this is diffuse large B-cell lymphoma. This means how confident the algorithm is in the call that it made. And what we see is pretty clearly that we get this split. So we have this split around 60% probability where everything that's pretty high confidence falls up here. And this is helpful for us for a couple reasons. Because one, we can say most of, with the 83%, the data that I'll show here, that's what I'm going to talk about. But this probability below the 60% can help us with cases that didn't have a bucket. And we'll talk about that in a second. So how did we do on this? Well, in the initial performance, we were at about 94% for our accuracy. Did really well with DLBCL. Our Hodgkin's cases are at 100%. Mantle cell and NKT cell lymphoma, we did very well. A little bit more difficult with our T cell because frankly, it's a pretty heterogeneous disease, and that's something we're working on now. Follicular lymphoma, and then we just didn't have very many marginal zone lymphomas. And as you can see, our aggressive B cell lymphomas were a lot less. Importantly, when we look at our non-malignant cases, so this is benign tissue, we were able to get this at 100%. And we did have cases where we had patients who there was suspicion for a lymphoma and they received treatment based on that. We also looked to see how this would do with relapse, and actually a little bit better than I expected. I thought there'd be some pressure on the gene expression following treatment, but we still, with our relapse case performance, was around 91%. Again, limited numbers here, so less that we can train on. So when we did this training, we had to say these are our lymphomas or these are benign tissues. So there's certain cases that had to be excluded because that we wouldn't be able to train and validate on those. So those are really important though, because that's the real world, right? These patients are coming in, no pathologist is reviewing it, the clinical suspicion, it just could be lymphoma. So how did those do? And this is sort of where they fell. These are things that we didn't have buckets for yet, just really given numbers. And so the best that we could hope for these is that they would come out as indeterminate. And our sort of end use instruction for this would be if we end up with an indeterminate result, that's where we should put our pathology resources. That's where we should pay for a little bit more IHC. And what we found is that we actually did pretty well with that. That was our only thing that we could get. And we ended up with 78% of these did fall into that indeterminate category. So how does this sort of line up? What does it take to run this? We need one technician to run it. We've had several different technicians, and really most of the expression data was generated in Guatemala. So we have a few of our colleagues there. You need to be able to pipette pretty well, but that's about the extent of it. the machinery is where things can get tricky. So we need 2 PCR machines to run the assay, and those can be the most basic PCR machines, and then a capillary electrophoresis machine. So a lot of our colleagues in Central and South America have these at their centers already. They're used for a bunch of different kinds of assays. But I would say that's a big limitation for implementation, is just finding access to one of these machines. And we're working on a couple of different ways around that. And then for cost, right now, the cost of reagents and running everything, and then just we've costed this in Guate, but every country's a little bit different. But getting pipettes and tips and all that stuff, we run it for about $10 per sample all the way through. So what are we doing now? We have a prospective cohort of cases that we're doing with Guatemala, El Salvador, and Belize. We are also starting a project with our colleagues at the University of Cape Town in South Africa, primarily focused on HIV-positive lymphomas, because we expect some of the gene expression to be a little bit different there. And then finally, we're working on a second version of the assay. We can add a lot more genes to it than we did in the first one. So we're taking what we learned and we're moving from there. And so I'll stop there, but I do want to acknowledge a lot of people that have contributed to this work, as you might imagine. And first off, our INCAN team, which is led by Dr. Fabiola Balvert, the team at Dexterity, who's been very supportive of our project. Stanford's team of Dr. Nakunam and Dr. Silva, who did all of our gold standard pathology. And then our team at Dana-Farber, which is led by the PI David Weinstock, and Kristen Stevenson, who led the machine learning on the project. So with that, I will stop and look forward to hearing the rest of the talks and discussing further.
Thank you, Dr. Bierczak. That was excellent. We'll move on to Dr. Brock.
All right, I think, am I good? Can you hear me and can you see the screen?
Yes.
2 seconds. Okay, so I'm, this is working, yeah, here we go. So I'm going to talk a little bit about the molecular assays for breast cancer. Now, we have multiple prognostic factors, the traditional prognostic factors that we use to decide how best to treat a breast cancer. You know, this is the subtype of the cancer, the grade, the biomarker profile, etc. And what I think is very interesting is that molecular assays can identify all of these key prognostic factors, except for the stage. And by stage, obviously, I mean the size of the tumor, the number of lymph nodes positive, you know, whether it's ulcerating skin. So that's the only thing that the molecular assays really don't do at all. If we look at how relevant all of these prognostic factors truly are, it's very interesting. The subtype of cancer, and for example, ductal versus lobular versus metaplastic, it actually isn't that relevant to deciding how to treat the patient. The only exceptions to that are the translocation carcinomas like secretory carcinoma and adenoid cystic carcinoma, which are incredibly rare, but it's very important for a pathologist to see those and recognize them because the treatment is different. The tumor grade, well differentiated or poorly differentiated, again, is incredibly useful. And you can, there are multiple gene assays called the genomic grade index, or single gene assays like Ki67 or Aura kinase that can determine the grade by molecular assay. Obviously, the biggest one is ER/PR and HER2. These are absolutely essential. And when we look at these at the molecular level, the PAM50 assay identifies these. And we break them down into 4 groups for molecular evaluation of ER/PR and HER2. There's what we call the luminal A and the luminal B. These are ER-positive tumors. Now, the luminal A tumors are low proliferation. They're the well-differentiated ones. And the luminal B are the aggressive ER-positive tumors. Then you've got the HER2-positive ones and the basal ones. And the basal ones are ER/PR, HER2 negative. Those are the triple negatives. When it comes to chemotherapy sensitivity assays, there's a molecular assay. You've probably heard of it. There are several of them out there, a good half a dozen. Oncotype DX is the big one in the US, but these are essential in high-income countries. And the reason is that there's a huge amount of luminal A, that well-differentiated low-grade ER-positive cancer in high-income countries. And so the chemosensitivity assays are only really for estrogen receptor positive disease, and they identify patients who don't need to get chemotherapy. So although the assay assays are insanely expensive, like $4,000 an assay, they actually reduce healthcare costs in high income countries because fewer women end up getting chemotherapy. Now, what's really interesting is across low income countries and particularly across Africa, there is very little luminal A disease. It's almost all luminal B, HER2 positive and triple negative. And so these chemosensitivity assays are not I don't think they have any value really in low income countries. So I'm going to talk about ER/PR/HER2 assays, and Dr. Asteria has already mentioned the STRAT4 assay, but I want to give a little bit of background to this. So when we do the biomarker assays, we typically do protein immunohistochemistry, and then when you have an equivocal for HER2, if you have it available, you'll do a FISH or in situ hybridization assay. And there's absolutely no interest whatsoever in high-income countries in switching these assays out, changing it all up. We've spent decades optimizing them for quality and accuracy. That said, it's really good to take a look at mRNA assays for these biomarkers. So if we look first at estrogen receptor mRNA and compare it with protein, the question to ask is, does the assay predict response to endocrine therapy? That's all you want to know. You want to know if it predicts response to endocrine therapy. And the interesting thing is that with protein immunohistochemistry, it doesn't accurately do it. It has this non-linear relationship such that you can get a low positive ER result that I can use my pen. Here we go. Pen, no, highlighter, laser. There we go. All right. Can you see me? Oh, shoot. Okay. Can you, you can't see me marking that. See the red arrow? You can see that where the red arrow is, you have a positive protein result, but you have got no response to endocrine therapy. When you compare that with mRNA, so now look at the green arrow, you see that there's a linear relationship between the mRNA expression of ER and the response to endocrine therapy. So in other words, if you have a low level of mRNA, you don't respond to endocrine therapy. If you have a high level, you do respond to endocrine therapy. So the bottom line is that very surprisingly, and not many people know this, the mRNA levels of estrogen receptor are actually a better assay for endocrine therapy sensitivity than protein immunohistochemistry, which is really good to know that. All right, if we ask the same question about HER2, now HER2 mRNA does not linearly correlate with response to HER2 targeted therapy, for example, with treatments like Trastuzumab. But then neither does protein or FISH. And so you actually get the best benefit from basically Trastuzumab therapy in the mid-range of mRNA expression. And mRNA is not better, but it's not worse than immunohistochemistry and FISH. And when you look at the concordance between all three assays, protein, mRNA, and FISH, they're all about the same, about 84 to 87% concordant. So moving on to the STRAT4 assay, which is an ER/PR/HER2 and the proliferation marker Ki67 mRNA assay. Let me tell you a little bit about it. So basically, it runs on a point of care platform that many of you will be familiar with, the Gene Expert platform. You take a tissue block, an FFPE tissue block, you cut a scroll from it, you stick it in an Eppendorf with the lysis reagent, vortex it up, stick it in your STRAT4 specific cartridge, put it in your machine, and a couple of hours later, you get your results out. There are huge numbers of Gene Expert machines all around the world, over 15,000 in low and middle income countries, 46,000 worldwide. And that's because it's very widely used for TB tests and more latterly for COVID testing. The STRAT4 itself, the data published to date and the data that's also not published shows excellent concordance with protein and FISH. There are 5 studies, many of them focusing on HER2 cut point, as that's what the company has had some challenges getting accurate. There's 98% overall concordance with ER and 97% HER2 concordance with centralized testing of ER and HER2. And I'm aware of 12 sites across Africa that have tested the assay so far in different formats. So just a couple of slides on the data that's published to date. This is one of the centralized, one of the major centralized testing concordance studies. And again, just to show you that the concordance, for example, with the estrogen receptor and with HER2 is extremely good, over 99%. Here's another study from JAPAR-X data. specifically looking at the HER2 concordance. They got, again, an excellent overall positive agreement of almost 95%. The real question, though, is how does this assay perform in low-income countries? And so we have looked at this in tissue that was fixed and processed in Rwanda, although the immunohistochemistry wasn't done there. The immunohistochemistry was done here at Brigham and Women's Hospital in Boston. So the goal of this study, and what I really wanted to do, was to prove that the assay didn't work, or at least try and work out why it was going to fail and when it was going to fail. So we wanted to really challenge the assay. Now, we knew that the tissue from Rwanda had an unknown but often prolonged cold ischemic time, and we thought that would be a problem. I wanted to test very small tumor areas like core needle biopsy specimens, just to make sure that it could work with small volumes of tissue. When we first did this study, back then, Cepheid were telling us we had to micro dissect tumor off of a slide. And I said, no, we're not doing that. We just want to use a scroll of tissue and test it. So we wanted to test it with lots of normal breast tissue and all sorts of things in the background and see how well it performed with that. And we also wanted to test a concentrated version of the reagent so that it would cut the costs of the lysate and the proteinase K liquids that you had to mix with the specimen. And so this is our data. We tested 150 cases. We had a 2.6% fail rate, which I think was okay. We had, in our study set, we had 55% ER negative and a quarter of them were HER2 positive. Now, this is absolutely the distribution of breast cancers across Africa. It's about 50 to 55% ER pos and 25% HER2 positive. That's very different from in high income countries. We had a concordance of 92 to 93%, much lower than the centralized testing of 97%, but I was not surprised by that. And I actually think that that's excellent. When we looked at the discordant cases, it was very interesting. Almost all of them were what you would call false negatives. So they had low levels of very weak protein expression, and so they were called positive by protein, but they came up as negative on the mRNA assay. Now the question is why? Were they truly tumors that wouldn't respond to endocrine therapy, or was it perhaps because these were the tissues which had a very prolonged cold ischemic time, and maybe I think probably mRNA is more susceptible to cold ischemic time than even protein is, and so it's possible that the prolonged cold ischemic time is what brings that assay concordance down from 97 to closer to 92, 93%. Looking at the HER2, it was superb. We had a 97% concordance, and in fact, in our discordant cases, of which there were 3, 2 of them, our protein results were wrong, and the STRAT4 assay was right. So the real question is, will the STRAT4 biomarker assay actually be the solution in low-income countries? And it really, first of all, depends on the quality of the assay. There's a lot of data out there to be published yet on the STRAT4. There's a 6-country data set specifically on HER2 that's about to be published that I'm aware of. Another major thing is the cost of the assay. And Harvard HMS student, who I think is even on this call right now, Parsa, did a lovely dissertation on looking specifically at cost-benefit analysis of doing STRAT4 in Rwanda. Now, from that study, it cost about $70 to perform the immunohistochemistry, the ER/PR and HER2 immunohistochemistry in Rwanda. Now, we don't have a fixed price for the STRAT4 cartridge yet. It will be viable, and it will save money if that cartridge price is somewhere between $30 and $50, which I think everyone is hoping that it will be, certainly not more than that. Parser identified that it would save technician time, 50% less technician time compared with performing immunohistochemistry, because of course immunohistochemistry is a multi-step process with a lot of reagents, etc. The other good thing about the STRAT4 is it eradicates that equivocal category of HER2, and Dr. Asteria was pointing out that most of her HER2 immunohistochemistry gets called equivocal because it's a really tough assay to read, and so it can be up at least a quarter of your cases that you stain with HER2 can be in the equivocal, so that gets rid of those completely. Great turnaround time, 2 hours, you can't complain about that. You can also use the Ki67 as a surrogate grade marker if you have issues with grading histologically. But for me, the real benefit of the STRAT4 is the quality control. It's that internal quality control. It's not having all of the nightmare of having to run an immunohistochemistry assay with technicians who struggle to do, to keep the quality of the assay. And we've already seen this in Butaro, where they've had issues reading the HER2 assay, even with access to the immunohistochemistry. They've had issues with the quality control of that, and the STRAT4 has been right every time. Another big one is availability of the assay. I know for Cepheid, the pandemic put a hold on just about every assay that they were developing as they rolled out the COVID tests. I'm hoping that they have more bandwidth now to actually start producing the STRAT4 cartridges. I know there has been a shortage of those. And so really the availability of the assay and getting it out to low-income countries is, again, a big issue, but hopefully that will be something that can be solved pretty rapidly. And I will stop there. Thank you.
Okay, excellent. Thank you to the three speakers for the excellent presentations, and thanks for being on time as well. So there are already some questions in the chat box, but I will start with one question and then I will let the other folks chime in as well. So, both of you who presented on the lymphoma and the breast cancer validation studies sort of have shown these technologies as potentially being, accurate in LMIC settings. And obviously there's a lot of additional considerations. And I think, Jane, you talked about some of those additional considerations. So sort of reflecting on, what are those additional things that countries in sub-Saharan Africa sort of have to think about for potentially implementing these technologies in their settings?
I can say a little bit. I mean, for me as a pathologist, I think it's the quality of the tissue, right? You can have the best, molecular diagnostic assay in the world, but if you haven't looked after the tissue from the time of taking it from the patient and getting it to the lab and looking after the quality of that, your assay is just going to be garbage in, garbage out. And so, that's something to really focus on, is that workflow of getting that tissue specimen well preserved to wherever it gets tested.
Any additional comments from Ed or from Dr. Asteria?
Yes, yes. For me, I think the most, in our setting, the most key issues here, we have to think about the policies, because these tests, these are new tests, and the way we are working now, most of these tests, when they're new, the government has to understand exactly what will be the cost implications, what will be the change in the workflow, how are they going to treat the patient based on this result. So before we think about the tests themselves, before we go down to the tests themselves, the government has to buy the idea. So it's like not the bottom up, it's rather than it's coming like up toward going down the bottom. So if the government doesn't buy the idea, it may be very difficult to implement these kind of tests. So these are some of the issues that we really need to focus in when we also continue focusing on the tests themselves and how we're going to implement the test. But we also have to think about the other sides of the policies and the people who are buying these ideas. And yeah, so these are some of the issues that I'm thinking right now.
The only thing that I would add is I think participation is going to be really critical in any assay where we're developing based on a gene expression. So, I mean, one of my worries, and I think one of the ways that we're going to have to pressure test any of these expression-based diagnostics, like we're talking about lymphoma and looking at for some other things, is we need as many populations feeding into that learning as possible. The worry would be that we develop this on a very limited population, and then this isn't going to be reflected in the reality, both in the distribution of the types of cancers, in our case, lymphoma, as well as maybe some variability in expression levels.
Folks can ask their questions. I think, Ophira, you had a couple of questions in the chat box.
Thanks.
I can deal with Ophira's questions from the chat box if that's good.
Yeah, and I was going to say also, I don't want to monopolize. I've got lots of questions, but there might be other people too. And or Jane and I could talk after, but excellent presentations. Go ahead, Jane, if you just wanted to tackle one.
Yeah, so you're asking about the depending on how, again, it's the specimen handling and how that changes the ER profile. You know, I used to be very skeptical about the ER distribution in Africa, and I thought it was cold ischemic time, and I thought it was, you know, that was why. But the truth, I mean, but when you actually look at well-preserved, you know, there's been a bunch of studies now, like there's a Nigerian study where they really have shown that you just do not have that luminal ER positive disease. You know, the ER positive disease, it sits somewhere between 50 to 60%, you know, and then you have a really high level of HER2 positive disease. Again, it's genetic, right? It's just, you're not getting the obesity related postmenopausal disease, and that's why it is a different disease across most of Africa. And obviously, as Africa gets more, you know, more wet, you know, more like a high income countries, and they have a lot more obesity, I think they will see a rise in the luminal A cancer. But for now, you know, the disease burden is really aggressive, ER positive cancers and HER2 positive, etc.
And just so people understand, when you say genetic, you're talking about tumor genetics, not necessarily genomic, because we've got the most diverse population in the world. Tumor genetics.
It's basically the cancers that people are getting are the really aggressive ER1s, and it's definitely just the proportions are different, and that's the way it is. It's the way it falls out, and it's for real. And I think in Asia, it's in between, right? You know, Asia seems to have more HER2 positive disease, and the ER seems to be about the same as in high income countries. Your second question was, how do we use STRAT4 to decentralize diagnosis? And it's a kind of
the availability of it to encourage people to accept that breast cancer is a thing in my country, and we can do something about it. Maybe it's the diagnostic pathway. People sometimes think this is diagnosis. It's not. It's part of it's collaborated risk stratification, prognostic, et cetera, once you have a diagnosis of invasive breast cancer. But what's out there from any of the speakers regarding diagnostic capabilities? I heard about methylation assays and other things, or is that beyond the scope of this?
Yeah, I've heard about methylation assays too, as a cancer, no cancer type of molecular assay. There's not anything published yet. It's all in the research stage, so it's hard to talk about it. And it's, again, you know, we know that the STRAT4 assay actually works on FNA samples, fresh tissue FNA samples. Again, nothing published out there yet, but we know it does. And that, you know, that we know is coming down the line, where you could in a clinic, in a mobile clinic, in a patient clinic in a rural area, you can stick a needle into a breast mass and just put it straight into, you know, into one of those STRAT4 cartridges, and you'll actually get the result. And you'll get your.
It's not going to say cancer or not cancer, though.
No. Then, but if you know it's a cancer, and if you can, you know, if you can do a smear and look down if you can look down the slide at it and say, yes, there's cancer cells here, and then you've got your biomarker profile. But you know, there's a lot coming down the line. It's just, I think it all went on hold because of the pandemic.
Thank you very much. Thanks.
There's a question from Raphael, sort of talking about you know, other type of ancillary testing. So if I could sort of like add on to that question, because we've heard from all the speakers the challenges of immunohistochemistry and the challenges of other types of diagnostic pathology things. And I don't know if this is an apt analogy, the analogy of landlines and mobile technology and mobile phones, and how, you know, there was a time where, like when I was a child, where a lot of African countries are trying to build landlines. So, you know, understanding that many of these countries have limited resources, where would you sort of advise people spend their energies? Should they start with just a thought of where should people be spending their energies, and should they be thinking more along this molecular stuff and spending a lot of time and money on that, or should they be thinking about really building this old capacity that we know works in a country like the US or other high-income countries?
I don't want to monopolize the conversation. If anyone else wants to tip in, please do. for me, I think, you know, you just use what you can, right? It's like to reinvent it and do it a different way. I mean, that's absolutely the solution. Like mobile phones are the solution. When you, I think what's interesting, if you look at like nurse navigators, basically organize everything in high income countries. And, you know, a lot of them use their cell phones to do it. You know, they'll have an app that will, you know, help them navigate, get the patient through the various, you know, helps them book search. They tell, you know, the app tells them who's got what, where. Like, this is the stuff that should be and can easily now begin to be introduced across Africa, because, you know, 50 to 60% of adults across Africa do actually have a cell phone and could have an app on their phone that can help with the navigation process, even with carrying your, you know, your medical record around with you, you know, in digital format. You know, this is where we should be going, and it's where we should be, you know, putting some resources into that. And not trying to recreate the workflows that are in the high income countries, because it's not necessary.
Yeah, I would add to that. I mean, I'm pretty biased here, right? Because I think that the molecular and the expression assay is where everything is going. I think we're going to be really slow in high income countries to do it, because we have a sort of stable pathway to make diagnoses. But I do think this is where it's going. I think it's really hard to make recommendations based on resources, because right now, a lot of these tests are new. And so to say you should dump everything into molecular, but I think starting to think along those lines, and if there are opportunities in country to develop molecular assays, that's where I would go. That's where I would be putting at least my research ideas, rather than trying to create other ways to do IHC itself, because I think that you're going to run into the same problems. And then the moment we get a new marker for a new disease, we're going to be right back to where we started. So I really think molecular is where we'll all be in a few years. But I think in lower resource areas, there's a need to jump the line on that, and can really offer the solution.
Yeah, I will also add on that, because I think the molecular is the way to go. And I think in the near future, people will start doing the cost impact of these tests, and we can compare the cost between the two. Because in most of our countries, we may dwell more on knowing the cost. That's why all the time when you introduce the gene expert and the molecular people, they will just pop on and say, what about the cost? It's expensive, it's a cost. So I think the way to go is when we do all these tests in terms of the research, but we also need to focus on the cost impact of this test. And then when we introduce this into our routine, we know exactly cost. And then when we try to advertise these people, they can understand exactly what they should expect in terms of the cost, because this immunohistochemistry in our area is costful, and because one antibody is $50, like for one estrogen receptor is $50. So if it 3 is 150, and it's expensive. So what Jen has demonstrated is that the cartridge for Gene Expert may range between 30 and 40. So I'm not sure how we work here in Tanzania. But I think if we know the exact cost and we can compare, we can be ready to go for that, because everywhere now in Africa, people are trying to find the solutions of how we can have another way of doing these biomarkers with reduction in turnaround time and more quality result. Thank you.
So we're getting close to the end. I will allow maybe 1 or 2 additional present comments if anyone wants to speak from any of the attendees.
I can see in the chat that someone's asked, is it the same Gene Expert for TB testing and for hormone receptors? It's the same platform, it's a different cartridge, right? So you have assay specific cartridges. And so you buy a TB cartridge, you buy a CML cartridge, you buy a STRAT4 cartridge.
Any present comments from anyone? Okay, so this was excellent. Thank you to all the 3 speakers. I think learning about these newer modalities and newer molecular techniques, I think, are quite helpful. Hopefully, this also spurs collaboration with regards to research collaborations and folks who might be interested in things like this. The presentations will be shared with the group. I think I'll turn it over to Mishka or one of the other coordinators if there are any announcements or comments.
Thanks, Dio. Yeah, actually, I will turn it over to Charles, who has been facilitating today. Thanks, Charles. And thank you, everybody, to all the speakers and to you, Dio, as well, for great facilitation. Over to you, Charles.
Thank you very much, Mishka, and thank you, Dio, for moderating our session for today. Thanks again to our speakers, Dr. Sasteria, Jamie, and Edward, for the excellent presentations, and indeed for our participants for joining us today and being active. So as Dio has said, we are going to share the slides and the recording on Basecamp for reference, and we can also continue with the discussions over there. So if you're not on Basecamp, you can get in touch with Mishka, and she's going to add you there. So our next session will be held 2 weeks from now, that is on June 16th. We are going to be focusing on WHO Global Cancer Initiatives and the implementation in the African region. So we will be having a panel discussion on the same. So look out for the agenda in the coming week, and if you have the details on how to join, and we hope that you can join us then. Our steering committee chairperson is here. Amaka, I don't know whether you have anything to add.
Well, nothing more from me, just to say thank you to all our speakers. It was really a very fascinating presentation. Thank you. Charles?
So thank you very much, everyone, and have a good evening. Thank you.
Thank you.
Thank you.
Thanks, everyone. That was awesome.
Thanks, everybody.
Bye.